So first of all, for cardiac cath, the potential is now that you might get a cardiac cath patient. Right now, post-procedure, the patients are going to 8-tower or, if need be, ICU. So you guys will be the other option if need be. So first, it still will be 8-tower because that's their expertise. And also, remember that because they're a great, great resource. They've been doing this recovery, post-recovery for many years, and a lot of those nurses have been through that for many years as well. So utilize each other for their, your expertise. The other thing is, so just to give her credit, the PowerPoint is Tammy Higgins' PowerPoint. She's an APRN in cardiac cath. Great resource. She used to be in nursing ed also. I don't know if you guys that have been here a while remember her, but she's a great resource, and they're always there for questions and stuff as well. When we start getting the cardiac caths, we'll have all the numbers that you need to call also, because you will be calling them. You're not going to be calling, the general hospitalists or interns or residents, because the APRNs and the cardiac fellow are the ones that are on call when the cardiac cath lab closes. So we'll have their telephone numbers in case you need to call them. Right, there's always someone on call 24/7, right? And they're very, very responsive. Oops. All right, so cardiac cath. It's the insertion of a catheter into a chamber or vessel of the heart. It can be done either for diagnostic and or interventional purposes. The angiograph is done with an injection of contrast dye and x-rays to view the coronary anatomy. So since we are injecting dye, we also need to make sure that someone's kidney function is up to par as well, because they need to be able to excrete that dye. It allows for visualization, characterization, and measurement of coronary plaque, and it is the gold standard for cardiac disease. It's performed on patients with abnormal results, on non-invasive testing. So it can be done for a lot of different reasons. On patients with coronary artery disease and having recurrent symptoms, history of MI, history of cardiac arrest, and if they have heart failure. So on this slide, and yes, you do have the handouts, right? So you can follow along. And by the way, for those of you that were on 9-tower, I don't know, I remember yesterday some of the gals remembered this presentation a bit, because 9-tower was going to be getting these patients, so hopefully it's refreshing some of those memory cells for those of you that were there a couple of years ago. So now, as opposed to 2 years ago, this actually has flip-flopped. It's more likely that you're going to get a patient that has had the procedure via radial artery versus the femoral artery, because now the docs are a lot more comfortable with that procedure, and it has a lot less complications, and the patient can get up and get around. So it really is great for the patient, and again, since there's less side effects and complications, it's really good for recovery. So we're going to see more of the radial artery now versus the femoral artery. In order to have it done radially, the patient has to have a normal Allen's test on the affected side to assure adequate circulation. So an Allen's test, I also gave you a handout, just giving you an overview of a quick Allen's test. So the Allen's test is you're occluding the two arteries in the hand, the radial and the ulnar, and the patient squeezes their hand, opens and closes, and basically the hand is supposed to lose circulation and turn white, and then when you release the artery, the idea is we want to see the blood flow back within 5 to 15 seconds. And in that case, that's what we're looking for. And then we'll know that it's okay to go in through the artery to do the test. So that's how they test, to make sure that that's the way they're going to go. However, just like Girl Scouts or Boy Scouts, we want to be ready for anything. So to prep the patient, if they're going to start out on PCU and then go to cardiac cath for an emergent cardiac cath, we also want to prep the groin area just in case, God bless you, just in case they have to go in that way because something else happened with the artery, the radial artery, and they weren't able to proceed. So we prep the patient's groin by shaving the area just to be ready in case they have to go that way as well. And you'll know which way they're going to go. There are very detailed pre- and post-procedure order sets on Sorian. They're very, very detailed, really very good now, so you can follow it step by step, so you'll know what to do pre- and post-procedure. Okay, so the PCI, percutaneous coronary intervention, includes angioplasty, insertion of a bare metal or drug-eluting coronary stent, atherectomy or thrombectomy. PCI is for patients that possibly present with a STEMI, and remember that's the ST elevation MI. And it is the gold standard to do a PCI within 90 minutes, the door-to-balloon time. We're very proud of our door-to-balloon time. Early intervention and reperfusion provides better patient outcomes. Pre-procedure nursing care, you're not going to see pre-procedure elective cardiac caths on your unit. If you have a patient pre-procedure, it's going to be emergent. You'll see patients post-procedure maybe elective, but not pre-procedure. But just like with any procedure, you want to make sure that there's an informed consent. There is a patient education handout on the intranet if you want to go over that with the patient. And again, just like any other procedure, they should be NPO. And all the allergies, there should be a baseline EKG, and all the necessary lab work. So it is just like they're going to the OR. And vitals, height and weight, like I said, we want to make sure the groin areas are shaved. You want to locate and mark the pedal pulses, and I did give you a handout just showing you the different areas of the pedal pulses on the side and then on the top, and then this is another little doodad for the pulses. Okay, make sure they're neuros, pain level, lung sounds, etc. are all assessed before a patient goes to procedure. And again, there are pre-procedure orders that you're going to see. So if the patient needs 2 lines, that'll be ordered. Most likely, you'll at least have 1 line in them, and they'll start another line in during the cath. Medications will be ordered. Want to make sure patient isn't allergic to dye, and you want to make sure that pre-procedure heparin products, anticoagulants are held.
Why no mucomist?
sure. Mucimist, doesn't that work on the liver? I don't know.
You use it for renal protection. In contrast, I don't know what I know.
Because that's what you give for the Tylenol overdose. So post-procedure assessment and management, there is a cardiac cath recovery record. It's a hard copy, so it's not in Saurian. And that documentation will start in the cardiac cath lab and follow the patient onto the nursing unit. So it's a flow sheet, so you would go along with what the requirements are on the flow sheet. And the other thing is you want to make sure you get a really good report from the cath lab nurse. The cath lab nurse will be bringing the patient to the unit. So there will be a face-to-face report because there's a handoff also of the document besides the patient. You need to go to the bedside, make sure you're looking at the site that was accessed, and there's going to be a handoff of the paperwork so you can go through and see what was done and the latest vital signs, etc. As well as you're going to have a handoff of the syringe if it was a radial access, and we'll go through that in a few minutes. So these are just the type of things that you're going to get report from the nurse about. And again, you're going to observe and document the assessment of the puncture site prior to and after each progression of activity. Again, you're going to be following the flow sheet. Palpate and document presence and strength of distal pulses, so that's all part of the assessment, the pedal pulses. And of course, check for any paresthesia, change in appearance, or any pain. Obtain vital signs, site assessment, and pulse checks. So we'll go through the policy real quick as well. There is a policy that I gave you on the cardiac cath recovery guidelines, as well as the radial pulse guidelines. So again, post-op is like the patient is coming from the OR, almost. So you're following these guidelines as far as vital signs. So for the procedures, most of the time, the patient will be in the cardiac cath recovery at least an hour. So they'll have done that every 15 minutes times 4, and then they'll come to you. But again, you're going to have that handoff, so make sure that that's where we're at as far as the vital signs. Unless the patient's unstable, then you might have to do the vital signs more frequently. But that's a nursing assessment that has to be done. Each patient obviously is individual. Post-procedure, maintain accurate intake and output. Again, we want to make sure that the patient had the dye, so we need to make sure they have adequate I and O going, and they're going to have IVs infusing as well. Continuous cardiac monitoring for any new ST segment elevation or T-wave changes. Administer pain medications as needed. So the sheath removal, this is all done during really the post-procedure, really before the patient even goes to recovery. The sheath is sort of like the guide wire that was put into the vein to open it up so it could be visualized. So that sheath is pulled before the patient comes to the unit. Groin site management. This is all part of the recovery guidelines that's in the policy, but basically it's strict bed rest for 6 hours post-procedure. So you see, having the groin, if cardiac cath was accessed via groin, the patient has to stay in bed for quite a while because we really want to make sure that there's not going to be any bleeding post-procedure. So strict bed rest for 6 hours post-procedure, 2 hours if a vascular closure device was utilized. And right now, we're using mainly 3 different kinds, and you'll get that on report as well. And there's a brochure that comes with the patient as well from cardiac cath, and the patient then will get that brochure and card so that they carry it with them to show that that's what they had done and inserted. The head of the bed should not be elevated more than 30 degrees because we don't want to be putting pressure on that site. Log roll, immobilizer if needed. Patient may eat or drink as soon as sedation has worn off. And then we're going to advance activity slowly. First start raising the head of the bed, then the patient can dangle, and then they can start possibly getting out of bed. Again, there's very detailed post-op orders that you're going to see on Saurian. And along with that, good instructions to the patient to definitely call for any kind of pain, shortness of breath. They need to let us know.
Jane, if they go through the arm, do any of the bed rest orders still apply?
We'll go through that now. Post-cardiac cath, avoid the following activities for 48 hours. So if the patient is being discharged, they're going to get a list of all these activity restrictions. But again, also, while they're here, if they're still here, we want to make sure that they aren't bending or squatting, or when they're going down onto the toilet or whatever, they have to be very careful. Again, this is if they're being accessed via the groin. And again, some more post-op orders. And this would be if they're being discharged to home, pretty much right from cardiac cath lab, or 24 hours. If they're just coming to the unit just because they can't go home, maybe you're just holding them and it's extended care, which is then they're not really admitted. I'm not sure if that's what we're going to get on the unit, but if it's extended care, then they'll go home right after they're stabilized. And the other thing is medication compliance. That's a really, really big, important issue. We find that with any diagnosis, really, once patients go home, they're not compliant with their meds, and they're not compliant necessarily with going to the doc to follow up. So those are 2 big issues that we really, really need to make sure they are compliant with. So in order to help that, that the med-to-bed program is really something that, especially if the patients are on H-hour, they use it all the time. So that way we know the patient at least has their meds when they're discharged. So hopefully compliance is a lot better with medication access anyway. Some of the antiplatelet therapy that you're going to see post-op, the 3 main meds that we use are Plavix, Effient, and Brilliant, or Brilinta. And I am going to get a rep to come and do lunch and learns for the Effient and the Brilinta, because they really want to make sure you understand what their drug is all about. And they are used quite a bit here. And again, you'll see the post-op orders or post-procedure orders to start these, because we want to make sure that the patient's going to start being able to, the circulation will be good. Again, medication compliance is critical. There can be some complications. Complications are very rare, but anything can happen. We all know that. Complications, significant bleeding at the insertion site of the procedure. So that's a biggie, and that is the most frequent complication if there's going to be a complication. So we are really constantly assessing whether it's the groin or the radial access. Skin infection, MI or CVA can happen post-procedure, anywhere up to 24 to 72 hours after procedure. Allergic reaction to the contrast dye. Hopefully that's pretty much during the procedure or during recovery if you're going to see allergic reaction. Acute renal failure, again, we want to make sure that the kidney function's okay because of that contrast dye. And we want to make sure circulation's really good. Bleeding, we're checking the dressing, making sure everything's really firm and pressing on wherever the site is. If need be, we can call the fellow or APRN that's on call, and if the bleeding doesn't stop, they'll come and help out as far as that goes, to do other kinds of procedures to make the bleeding stop. Hematoma can be a side effect. So if you start seeing any kind of hematoma, you want to start marking the borders. And if it does start spreading, call the MD or APRN. Pseudoaneurysm can also happen. It's a hematoma that forms as a result of a leaking hole in the artery. Vascular occlusion, so that's why we're doing pedal pulse checks. And again, anything, call the people on call, that's what they're there for. Retroperitoneal bleed, perineal bleed, an accumulation of blood in the retroperitoneal space. So that can be very painful. Signs and symptoms are back or flank pain, restlessness, tachycardia, hypotension, decreased urinary output. Discharge plan is good discharging with education, just like anyone else. Make sure the patient understands their discharge instructions and activity restrictions. Review the medications like you always do, and make sure that they do have appointments set up. And then there is cardiac rehab that they do go through. All right, so the recovery guidelines. So I gave you a copy of the policies. So we have the policy of the recovery guideline, and attached to that is the radial artery compression device policy. It's all together in a handout. Right, so basically recovery, if you look at the recovery guidelines, you see that no matter what the patient had, pretty much 1 hour post-procedure, the patient can come to the nursing unit if they're being admitted to the unit. If they're going home, they stay in recovery a lot longer. So attached to that is the use of the radial artery compression device. We're using the TR band, which looks like this, and I'll go over how to use it. But the policy does go through what we're doing on the nursing unit as far as releasing the band. So on that first page, does everyone have the radial artery compression device policy in front of them? So it says recovery area down on the bottom of the first page. The circulating nurse will include final inflator syringe volume in the patient record. Nurse-to-nurse reports should include this information as well as perfusion assessment. So I should actually show you. So what happens is, this is the compression device that's put on radially. This is a picture of what it looks like on the arm, and I'll put it on someone's arm. Actually, does someone want to come up here so I can show you how to use it? There is a little dot here. It's a clear plastic device. So the dot marks the spot of the radial artery. So this is put on the patient, like a little bracelet. And then this is the syringe that's used. And there's a little balloon here, and then this gets blown up. So as you push air in it, you start feeling the pressure on that radial artery. So the idea is this is the pressure device so that post-op the patient isn't bleeding. Okay? Usually they use about 18 cc's of air. And then gradually post procedure, they're going to be releasing the air. And there'll be lines on the syringe. So gradually you release the air, 2 to 3 cc's at a time. When you get the patient, so you'll get the patient like this, okay? So you're going to be checking to make sure there's no bleeding here. The nurse will hand off the syringe to you, okay? And let you know how much air is still in here. Is there?
Yes.
Okay. So, you don't want to occlude your artery. So you're pulling air out. Good?
Yeah.
Okay. And a little bit at a time. So you release 2 to 3 cc's at a time. See that there's bleeding or not. Wait 15 minutes, release another 2 to 3 cc's. If there is bleeding that occurs, you're going to put that 2 to 3 cc's back in. All right? Once you're totally done, and this comes off, if the patient starts bleeding, thank you. If the patient starts bleeding, you do not put this back on. You're going to call the fellow or APRN that's on call. But if it starts bleeding really badly, you're going to want to make sure you put pressure just above that artery and hold it for at least 10 to 15 minutes until then you can start releasing and make sure it stopped bleeding. If it really didn't stop, you need to call the docs because they need to maybe put it back on or do other things to make sure that the bleeding has stopped. Now, what I told the group yesterday, the nurses on 8 Tower, actually, we were used to releasing a lot slower. So what they've been doing on 8 Tower is releasing 2 to 3 cc's at a time, but waiting like a half hour in between. So we're gonna just kind of check and touch base again because this is a pretty aggressive release. And there haven't been complications, but remember also, as you see on page 2 of this, it says, for interventional cath patients, the radial band is to remain on the patient for 3 hours undisturbed. So the diagnostic is 2 hours before you even start releasing. So they may have the patient in cardiac cath for that long, and then they'll bring the patient to you, and you'll finish releasing. Now, for interventional, it says 3 hours undisturbed, and it says these wait times remain the same even if the patient had an anticoagulant like Angiomax. And a lot of times, most of the time, they do have an anticoagulant like Angiomax. So Angiomax is used a lot. They don't want the patient to be clotting up. But remember, if we're releasing that pressure, the potential is there that they could bleed. So that's why we want to make sure that they are clotting up before we we are too aggressive and release that band. So if you want to pass this around, just so you can see. And I did include discharge instructions for the TR band if the patient is to leave. But it also helps you, because one of the things is instruct the patient to avoid submersion of site in water times 3 days. No lifting with affected arm for 24 hours. And to answer your questions, Shelby, so post-op or post-procedure with this, the patient can get up, the patient can eat, the patient can go to the bathroom, as long as there's no effect from any kind of anesthesia or pain medication, they can get up right away and eat right away. So that's really nice, and that's why, it is a preferred method to use the radial artery rather than the groin, because the patient can get up immediately as long as they are stable and feel like they can walk around. Obviously, the first time you get anyone up from post-procedure, you're going to make sure that they're okay. So on page 2 of this radial artery device guideline, it says, so it has step 1, to release 2 to 3 cc's at a time. Step 2, when all the air is removed and there's no further bleeding, you can remove the TR band and cover the puncture site with gauze and clear adhesive. And if the TR band is unable to be removed for more than 6 hours, if you really can't, if they just start bleeding every time you're starting to remove the air, you need to call the APRN or fellow that's on call. Or if it's still, the cardiac cath lab, I believe, closes around 7. So if they're still open, you could try calling them. And then for documentation, diagnostic caths going to a nursing unit, either as extended recovery or as inpatient, go after 1 hour recovery in CCR. Interventional patients can be transferred after 1 hour as well. If it is during the day, the patients may stay there longer than the 1 hour, so that they can do as much as possible before they bring them to the unit.
So under the band, they don't put a dressing or anything?
No.
It's just...
Because you want to be able to see. So that clear balloon really is your pressure. And for the groin, it's we don't use sandbags or anything anymore. It's also a pressure dressing. So if there is bleeding, you have to, it's a manual pressure. Let's see. So the forms are hard copy, and we'll get them stocked on the unit so that you'll have some, but most of the time you're gonna just use the form that comes with the patient. And the order sets, like I said, are very detailed for pre and post procedure. So you'll follow those orders, and don't hesitate to call them. They're really have come a long way and very much open to communication now, which is great. And their manager is Joanne Russell. So I think many of you know her, and she's really done a great job making them open to really being a team. So that's good. Anything else? Good? All right.